And the more precautions you take,
A very good afternoon and a warm welcome to all our viewers. I am Darshika, member of the clinical engagement team at DocPlexus. It gives me immense pleasure to share that the month of October is going to be a special celebration of DocPlexus completing 8 glorious years. I take this opportunity to thank each and everyone on behalf of my fellow DocPlexians for your constant support and love over the past years. The DocPlexus team humbly invites you to be a part of the celebration this month and witness the launch of our brand new segments, the all-new MasterSeries, DocPlexus Surgical Suit, ACME, MediTV, DocPlexus Essentials, and much more. We go beyond our 99 medical specialties this time in our special A2IC Master Series sessions. These Master Series sessions are planned to discuss the nuances of specialties like genetic medicine, hyperbaric medicine, nuclear medicine, public health, burns, and microvascular surgery. So today's session is focused on the essentials of sleep medicine, where experts of the field will throw some light on the specialty, its role in other medical specialties, academics, career opportunities, and its future in India. Stay tuned till the end, where we also have a brief Q&A session where the panelists will take some questions by our live audience. So without further ado, I would like to introduce our speakers for today. Please welcome Dr. Joy Desai and Dr. Tripat Singh. Dr. Joy Desai trained in his undergraduate and postgraduate period at the BJ Medical College, Ahmedabad, with a spate of gold medals to his credit, achieving a position within the first 3 ranks always. He completed his neurology DNB at the Jaslok Hospital and Research Centre, Mumbai, and proceeded to the Royal College Hospital, London, UK, for a 3-year neurology fellowship. He has supervised and managed and followed up to 5,000 patients with purely controlled epilepsy over 2000 to 2010. He has successfully guided and counseled more than 80 patients with refractory epilepsy to undergo epilepsy surgery, and his main areas of research include epilepsy, neurodegenerative diseases, and the neurology of systemic diseases. His other passions also include trekking and philosophy. Talking about Dr. Tripat Singh is currently the Clinical Manager, Sleep Healthcare, Asian Philips Electronics at Singapore. In his current role, he trains doctors, nurses, and technicians in the field of sleep medicine and sleep technology in the Asian region and Pakistan. He specializes in sleep medicine as the International Sleep Specialist, that is the World Sleep Federation program, and the sleep technology as registered polysomnography technology and registered sleep technologist, that is an RST. He is a regular faculty for National Sleep Medicine course and Sleep Technology course in India. Dr. Singh is an associate editor of the American Academy of Sleep Technology book Fundamentals of Sleep Technology, which is considered a must-read in the field of sleep technology. Welcome to both the doctors. So starting the session by talking about the essence of sleep medicine. So my first question is to Dr. Desai. Why is sleep medicine such an important specialty?
Why is sleep medicine important, Steve?
Yeah.
We should actually be asking the question, why is sleep important? So it's very clear that many of us as individuals do not realize that we spend 1/3 of our lives sleeping, and it has a very important physiological function. So while we are dissociated from the surrounding world, so-called slumber, sleeping in bed, the brain actually is doing a lot of servicing, not only of itself, but of other body parts. So there are numerous physiological functions of sleep. If one really wants to know, the key one is actually memory consolidation. And nobody teaches that in medical school. One of the key functions of sleep is to consolidate, mold, and make your memories retrievable only if and only if there is a good exposure to deep sleep. And Dr. Singh is going to talk about phases of sleep, I think, if the question comes up. So that's one. The other is that almost all physiological functions, immunological competence, emotional salience, refurbishing the metabolic needs of the body, making sure that the blood sugar levels, the muscle health is optimized. All those functions occur physiologically when we are sleeping. And one can understand that if somebody has a sleep disorder of any kind, whether it is something that is identifiable by the standard textbook, or if it is something that is analyzable as a unique phenomenon on a bedside assessment of a patient's problems, all of that can have a huge bearing on almost all facets of life: blood pressure, diabetes, obesity, endocrine functions, cognitive functions of the brain. All of them need good sleep health. And I'm pretty sure as the program progresses, we can talk about the mechanisms behind this and how it is important for us to treasure our sleep, because that's your only restorative, which does not come in a bottle.
Thank you so much, sir. Dr. Singh, would you like to add something to this?
I think, Dr. Desai, you summarized very well, and that we spend 1/3 of our life sleeping. And I'll like to add over here that sleep is such a crucial part of our lives, spending 1/3 of our lifetime in it. And the sad part of it is nothing is taught about it during medical school curriculum. On the current data shows that only 2 hours are spent on sleep throughout the MBBS curriculum. Nothing is taught during MD curriculum. And there was an international survey across 20 countries, and around 10 universities in India were sent the survey to comment upon the state of affairs for sleep medicine in India. None of the universities responded to that survey. So 0 response went from India. So sleep being so important for everyone, including physicians, and totally neglected in medical schools. Like Dr. Desai highlighted that sleep cuts across every physiological function in the body.
Absolutely.
And in medical school, we learn from 2 people, never from sleeping person. We learn from waking people in the OPDs, or we learn from dead people in the dissection hall. What happens during sleep, nobody touches at all. And if you do not sleep for 1 night, I don't have to tell you, you know what happens to your mood, you know what happens to your energy levels, you don't feel like doing anything. And one more thing I want to add over here is, everybody is focusing for health on 3 things: diet, exercise, and a sound mind for proper health. But what they're forgetting is there is another component, the sleep. And Dr. Desai, that is what is being promoted, that sleep is the 4th pillar of health.
Yes,
and I want to differ from that. Rather being a pillar, sleep is the foundation of health.
Oh, absolutely.
On which pillars of diet, exercise, and mind are standing to give us the overall good health. Because if you don't sleep, you don't want to exercise, rather you want to go to bed and recover your lost sleep.
Right.
If you don't sleep, your appetite changes. There are hormonal changes happening in your body if you sleep deprive yourself, and you want to eat all the time. And the worst part of it is the changes that happen in your body with sleep deprivation. It elevates the levels of endocannabinoids in your body, which makes you choose all unhealthy foods.
Oh, absolutely.
All sugar-rich foods and all calorie-rich foods.
Oh, yes. High glycemic index foods. So.
And sleep is doing so much, like sleep deprivation is doing so much harm to you, that it becomes a very pertinent specialty in current times, especially when the society is getting sleep deprived. There is a current data showing that people are pushing back their sleep time for catching up on social media. People are pushing back sleep time for leisure activities, lying down in the bed, watching Netflix and Amazon Prime, binge watching. And it has been very clearly shown, if you push back your sleep time with sedentary activities, your cardiometabolic health suffers.
Oh, yes.
This data has currently come out. So
Yes.
I think I cannot agree more with Dr. Desai that sleep cuts across every function of your body, and the society is not understanding it because the medical community is not understanding it. So I feel sleep medicine is very important specialty in current times.
Actually, it's not a specialty, it's the foundation of physiology. And we have walked away from it because of the vagaries of history of medical training. I can add to one little secret that sleep neurology is not taught in the standard curriculum for neurology. And if you're a neurologist and you're asked a question as a neurology trainee in your second year, if you're doing your DM in neurology or diplomate of the National Board in Neurology, if somebody were to ask a first-year resident that, doc, in what did your teachers or guide teach you about the key essential functions of sleep, and they'll be lost because nobody talks about what sleep does. What is taught is how to identify a sleep disorder, which means a pathological condition that a patient may exhibit, which is obvious to the family, so they bring the patient to the clinic. But nobody is trying to understand what is the physiological fallout of sleep hygiene and the benefits of it, and what is the paramount abnormality that can occur in all our systems if we deviate from sleep hygiene. And if someone were to ask to write an essay on sleep hygiene, they would fail because we do not discuss sleep hygiene. What is sleep? How is it actually ordained? What is its physiological parameters? What is circadian rhythm? What is its mechanism? These are often not discussed in standard curricula.
So this brings me to the next question about what is the scope of practice and what career opportunities will be available on becoming a sleep specialist.
Dr. Singh, you want to take that, or I can join you after you're done. So
yeah, sure. Means you already are a physician, and what it brings on the table is you will have a much wider scope of looking at your patient's problems. Like how I see is you may belong to any specialty. You may belong to neurology, you may belong to medicine, you may belong to ENT, you may belong to endocrinology. Okay, what is missing right now is nobody is paying attention to sleep. So if you train yourself in sleep medicine, what will change is how you treat your patients. Sleep per se and diagnosing sleep disorders will come into your routine practice. Like you may have got hypertension patients, you may be giving all the time antihypertensive pills to the patient without even understanding what is causing hypertension in that case. It may be underlying sleep disorder which is causing hypertension and you're not treating the underlying cause. You may have a diabetic patient whom you're treating for controlling the blood sugar without understanding that a sleep disorder might be promoting the driver of the diabetes. So that is how your practice is going to change. A heart failure patient walking in and you have given all types of heart failure management to the patient, but patient cannot sleep at night. You will start looking at the sleep component of the patient, that they may be suffering from sleep apnea at night, and that will be more comprehensive and thorough treatment of the patient. And most important of all, what will change is your perspective towards the society's sleep health overall, where you will try to get involved in promoting the importance of sleep to the society in general. Dr.
And
Desai.
I couldn't agree more. I mean, we are all internists. We all did internal medicine before we did our specialty. So I did 3 years of internal medicine and then went into neurology. And I still consider at heart myself as an internist because the patient doesn't know whether he has a neurological problem. The patient says, I have a problem which is not making me feel healthy and I need to go and see a doctor. And he goes to see the doctor that he has been directed to by various forces in society. It is the doctor's responsibility on listening to the patient's story to ascertain that here's this individual who's not well. So what is the physiological basis for this? What is the physiological basis during his wakeful state? And is there a physiological basis of what could be wrong in his sleeping state? A simple example, you have a young person, relatively young person, not too old in today's time because of longevity. You have someone who's in their mid-40s and he's got hypertension and he goes to a physician. The physician evaluates him, examines him, takes his blood pressure, does his fundoscopy, organizes a test. What are the tests that a physician normally does? He does a biochemistry for renal functions, a blood count. He gets an ECG done, he gets an echocardiogram done, and he gets a renal Doppler done to find out whether there's a renal cause for hypertension. At the end of that, the patient is put on an antihypertensive medication. If this individual sustained has blood pressure despite 1, 2, and 3 medications, you've got to ask the question, why does he need so many medications despite all his other physiological tests being okay? Then you take a sleep history and you find that he sleeps late, he's fond of Netflix. You speak to his spouse and he says yes, he snores in his sleep. And you ask him or you ask her that does he go sometimes and have brief awakening and then goes back to sleep? She says, yeah, doctor, this has been happening since the time we got married. And does he ever feel sleepy in the daytime? So yeah, I mean, when he's reading a newspaper, he can doze off. When he's in the car that you're getting to Churchgate from Santa Cruz, he's often dozing in the car at 11 o'clock in the morning. So those are the red flags. They have to tell you that perhaps this gentleman has sleep apnea, as referred to by Dr. Tripat Singh. And you've got to evaluate because you get a sleep study done. If the person has sleep apnea, and we know there's a grading system for it, mild, moderate, and severe, you put them on CPAP if they have moderate or severe sleep apnea. Your antihypertensive medications will come down because our cardiovascular tone, our cardiovascular autonomic health, the health of our beating heart and its rhythm, they are all serviced when we are sleeping at night. So our sleeping brain is actually servicing all the body parts. It's servicing the kidney, it's servicing the heart, it's servicing the autonomic system, and keeping us relatively healthy. And despite the passage of time, so our health needs our sleep to be foundation, to be physiologically well aligned as it is ordained to be. And as you grow older, it also has a very important bearing. Sleep health has a bearing on cognition. In my practice, when I was in training, I was told that if a 60-year-old or a 75-year-old comes to the clinic with early memory impairment, you got to do a clinical evaluation, do B12 thyroid and an MRI, do a neuropsychological test. If he has only a little bit of memory impairment, but other cognitive domains are okay, we call that minimal cognitive impairment or MCI of the amnestic type. And such an individual would then be, say, given a medication like donepezil or memantine. But nobody asked the question that does this person's sleep memory problem, what is the physiological basis for it? And we all know that our memories are formed, consolidated when we sleep at night. So the brain has a small organelle called the hippocampus. All our experiential data is stored in the hippocampus. Then when we sleep at night and we transit from wakefulness into deep sleep, from non-REM 1, 2, and 3 to non-REM 3 and then to REM sleep, in that deep sleep, there is a very gentle slow wave activity of the brain. And it is this slow wave activity of the brain in the presence of spindles that yokes all the data transfer from the hippocampus to the larger brain parts. And this forms and consolidates our memories. So the brain decides which ones are irrelevant, the brain decides which ones are relevant, and stores them for retrieval. So a good number of people who have a memory dysfunction may have a sleep-related disorder. They could have shortened sleep timing, their sleep could be fragmented, they could have sleep apnea, and they could have frequent arousals in their sleep, not allowing them to get deep sleep. So you can imagine that optimizing sleep health and ensuring your sleep health can have such tremendous bearings on cognitive health, on the health of your cognition.
And I will corroborate your this suggestion to cognitive health by the recent finding that in brain there is a system called glymphatic system,
Oh yes,
which removes the toxic metabolites, especially those beta amyloid proteins which
Yes.
cause Alzheimer's disease.
yes,
So the glymphatic system is most active when you are sleeping, basically, especially in your deep sleep. And if you're not sleeping, your glymphatic system activity comes down, toxic metabolite clearance of beta amyloid does not happen. And if you
absolutely.
sustain this pattern of sleep deprivation, these beta amyloid proteins get deposited in your brain. And the
Yeah.
most recent study, which was published 6 months back, have shown if you're sleeping consistently for less than 6 hours,
Oh yes,
that is an early indicator of Alzheimer's disease.
dementia risk. Dementia risk. So this
Yeah.
is very, very important. So so in very simple terms, the brain has a cleaner, and the cleaner works only at night. This
Yep.
cleaner was discovered in 2013. So Mike and
Yep.
Nedegard from Rochester, New York, discovered it by accident in late December 2012, and she got the publication in place by August in 2013 in the Annals of the Academy of Sciences. And she demonstrated to the world for the first time something that we did not know, that when a mouse and a human being sleeps, a pure sleep activated cleaning system is activated. What is this cleaning system? The fluid that bathes the brain, the cerebrospinal fluid, has a gentle unidirectional movement. It moves from the arterial side to the venous side, and it is regulated by respiratory rhythm. It is regulated by pulsatility of the arteries, and it is regulated by the gating function of a brain cell called the astrocyte. If you have all of these things healthy, then this pure sleep-driven cleaning system works well. And in the next 2-3 years, they asked this question. If we have a cleaning system in the brain, they called it the glymphatic system. So we already had a lymphatic system in the body. This is driven by the astrocyte, which is a glial cell. So the glia and lymphatic came together to form the word glymphatic. And this glymphatic drainage, they asked the question, what does it do? And 3-4 years of experimentation, first in mice and then in humans, clearly shows that it removes from the brain beta amyloid and tau. So we now know that in all our activities of the day, in our experiential occurrences that occurred in the wakeful hours, the brain activity produces metabolites like beta amyloid and tau, which are cell proteins, neuron proteins. And the degradation products is a small fraction of that beta amyloid. It's called beta amyloid oligomer. It's called beta amyloid oligomer 4042. And this 4042 can accumulate in the brain, but it is removed from the brain at night when we sleep. So very interestingly, if you took a teenager and you sleep deprived that teenager for 2 days and measured the beta amyloid oligomers in the cerebrospinal fluid of that teenager during the sleep deprivation time, it shows patterns that are similar to those found in a patient with Alzheimer's disease. Then when you take that teenager and make them sleep repleted, that means you make them sleep optimally for that 8 hours of good sleep, the oligomer levels which you measure in the CSF come down. So this shows that even on a day-to-day basis, every day that we sleep, our brain is getting cleaned of amyloid and tau at night. And therefore, it is not difficult to understand that if in our life there are numerous nights when our sleep is compromised in duration, in depth, and in its physiological efficiency by, say, sleep apnea, it is not difficult to understand that it would enhance and drop the efficiency of this clearance, and therefore it would enhance the amount of amyloid and tau that accumulates, thereby increasing the risk of neural degeneration.
I think, Dr. Desai, you have highlighted very beautifully that once you get trained in sleep medicine, this is how you will start looking at those common complaints all together with the vision which you were all missing during all this time and during all your training. So that is the beauty of sleep medicine, getting trained in it and looking at patients from a new perspective. And beautifully elaborated.
Let me also give another example, which I think Dr. Singh should also discuss. That what he referred to as the pillars of health. We always talk about diet. So every doctor has a patient who comes to the clinic and says, "The doc, my diet is really good. I have a lovely dietitian who's regulating my diet, and I walk 60 minutes every morning in the park. But doc, do something. My weight is not getting regulated." Then you ask them that, "Babu, what time do you sleep at night?" So he or she says that, "Oh doc, some days I sleep at 1, some days I sleep at 11, but occasionally I sleep at 2 and 3 o'clock." Now, if you then take a little story, is that what do you do at night? So some of them are watching Netflix, some of them are working on projects. And what time do you have your dinner? "Oh doc, our dinner is always at before 8 o'clock. And what happens when you're doing your work at night?" So sometimes we have 2 scoops of ice cream. And so the thing is that if you have had your dinner at 7:30 and you have done some relaxing work till, say, 10 o'clock and gone to bed, you're not going to consume anything at night. But if you are watching Netflix or if you are doing work on your laptop till 1 o'clock at night, very likely that you will eat highly calorigenic food, which Dr. Singh referred to. And that stems from the fact that the brain has 2 peptides which regulate satiety and hunger. One is called leptin and the other is called ghrelin. And this leptin and ghrelin has a fine balance. And the moment you get sleep deprived and you start sleeping late, the ability of the brain to regulate leptin and ghrelin balance, to regulate satiety and regulate the urge to consume calorigenic food get disrupted. So you can imagine that we can missleep our way to obesity. And that's what we need to tell our patients, that please understand, it's not just exercise and diet. You want to have a good physique, you've got to sleep the way you are designed to sleep. And the human brain is designed to sleep 4.5 hours from sunset and is designed to waken with sunrise. And in my practice, when I tell my teenagers that you have migraines, they will improve if you sleep at 10:30, they start laughing. "Hey, doc, what 10:30? Koi sota hai kya 10:30 baje?" So this is a very big pandemic. It is as much more than the coronavirus.
No, I fully agree with you, Dr. Desai, that all these issues, common issues that come to the clinic, need to be seen with the backdrop of how the person is sleeping. Like I strongly believe sleep is the foundation of health, on which pillars of diet, exercise, mind are standing to support your overall good health. So like that is the beauty of this field, and that is how it can change our vision to the common ailments that we see in the practice nowadays. And all these young people dying nowadays, like those young Bollywood actors dying at the age of 40, physically fit. But what is missing in the media is how they were sleeping.
Oh, yes.
What they were going to sleep. What was their sleep health? Nobody's commenting on that. Just they are focusing, oh, he was so physically fit, but still suffered a cardiac arrest. But the issue is that sleep is being ignored in all these cases. So I think it's a very relevant discussion that Dr. Desai highlighted, and to bring to the forefront that sleep is the foundation of health. And I think that is the answer to this question, that what career opportunities. It's not the career opportunities, it is your current opportunities.
It is the opportunity of a lifetime, I think.
Will be seen in a new light, actually.
So my next question is, could you shed some light on the training involved in becoming a sleep specialist?
So there are two streams that participate in the training for sleep medicine. Traditionally, thanks to our misguided understanding, I think, of sleep. Traditionally, when I was in training 25 years ago, when I joined medical college in 1982, so 30 years ago, the understanding was that a person who is trained in respiratory medicine then goes on to do a fellowship in sleep medicine. And the respiratory medicine sleep training is essentially a little bit about sleep physiology, and largely focused on the disordered breathing in sleep, or sleep apnea and sleep disordered breathing, with some physiology, of course. And many neurologists were at that time under the impression that the scope for sleep medicine went via the respiratory tract. Then what happened is that as time evolved and subspecialties in neurology developed, a lot of people who did mainstream neurology, that means did MBBS, MD, and 3 years of either DM or DNB neurology, then took up 2 years of a fellowship in sleep medicine and identified disorders, neurological disorders of the so-called neurological disorders. But I don't think you can divide this. This is all disorders of sleep, whether it's neurological, breathing related or not. Every physician needs to know about it. So that was the second stream. So traditionally, you've got these two routes to get to sleep medicine. One is through the respiratory route, and the other is through the neurology route. And it is my dream that one day these two routes will be actually on the same platform, and neurologists with sleep interest and respiratory docs with sleep interest will be working on a common platform, because you can't divorce the two. What Dr. Singh pointed out about the lymphatics, that has completely changed the way we understand the key physiological basis or biological basis for sleep hygiene and sleep metabolism. And I would go to the extent of saying that the next generation of students who do sleep medicine will have some kind of should have integrated platform to understand respiratory physiology, to understand sleep physiology, and then in a holistic manner entrain the abilities to assess a patient on a holistic basis.
I agree with you that the traditional pathway was the pulmonary medicine, then neurologists took over, and right now both the streams are offering the training in sleep medicine. But more is happening nowadays, because there are for sleep disorders like obstructive sleep apnea, there is one form of treatment, that is the surgical treatment. So ENT community is coming into
Yes.
this field in a very big way. So the role of ENT, like once you are doing your MS in ENT, you can do short-term fellowships to get trained in surgical management of obstructive sleep apnea, and that is a very specialized field in itself.
Yes.
Another field that is coming up is the psychiatry. The psychiatric disorders have got sleep issues, and psychiatric programs are nowadays also offering training in sleep medicine. And currently, another change is happening in the whole perspective towards sleep medicine is that it is currently being recognized that sleep disorders should be picked up at the general practitioner level itself before even reaching the specialist. So a big push across the globe is to involve the general practitioners who are MBBS into the field of sleep medicine and train them in some basic aspects of managing the sleep disorders at their level, and then escalating the complicated cases to the specialist level.
Yes.
And with this vision in mind, World Sleep Society, which is the largest organization across the globe, has started an initiative of training physicians across different countries. And with that vision in mind, in India, a board of sleep medicine has been formed by Indian Society for Sleep Research, and they have brought the examination for sleep medicine given by World Sleep Society to India. And the board have decided to keep the minimum qualification as MBBS rather than a specialization. If you have done specialization, you are most welcome. But at least they are encouraging even the MBBS students to take up the field of sleep medicine. And if you can demonstrate that you have done 100 sleep studies with under the guidance of someone who specializes in sleep medicine, with your MBBS background, you can also venture into the field of sleep medicine. And I feel that is a big step towards creating an army of these sleep medicine physicians who are very few in country. This will encourage the youngsters to at least specialize right after MBBS, rather than going through 6 years of specialization and then super specialization training and then waiting to get trained in sleep medicine. So these are some of the steps that have been happening in India, and these are the current educational opportunities in India.
That's phenomenal. I think one has to look at it in a broad perspective, and thank you, Dr. Singh, for introducing us to this concept. But one should look at it in a holistic way, and there is a big need for people with MBBS training also if they are interested in the subject. Ultimately, it's your passion. If you have the passion, you're going to learn. It doesn't matter what's your background. You can be a general neurologist. I am not a sleep specialist at all. I am a general neurologist, and I am a trained epileptologist. But from my epilepsy practice, I gathered that there's a lot that we don't know about sleep, and I started to study it. And then I got trained because of my interest. So I attended conferences in sleep medicine and got certified. And then went into practice and utilized what I'd learned. So the route to assessing and treating sleep disorders can be numerous. We also need, I think, different tiers of specialization, because one has to understand that the complexities of human physiology are so many that if one is a good internist and then a neurologist, you will deal with that 40% of neurology which has a internal medicine basis. And the same way, there is a room for these different tiers to function across, say, a big pyramid of dealing with people. So the patients who have a screening to be done, identified by an MBBS doctor with a sleep interest, that's one step. But if they have some complexities, they can see an internist or a respiratory doc who has a sleep interest. And if they have some neurological thing too, and that will need a neurological input. Say, for example, let me illustrate that. I deal with a lot of geriatric patients now in my practice because I work in an area where there are people who live longer in the city of Mumbai, and they all have some degree of neurodegenerative disorders. And I find that there's a very large incidence of sleep disordered physiologies in these elderly people, which goes often unrecognized. They are catalysts and contributors to the neural degeneration. So they are genetically vulnerable to, say, either Alzheimer or Parkinson or Lewy body disease. Comorbid, they have a sleeping disorder. So we treat the degenerative brain disease, we don't look into the sleeping disorder. And that becomes a catalyst for making them rapidly go down in their trajectory of illness. So this geriatric understanding, and now there is new data. There's a publication from France just about 5 months ago, which shows that in a 70 consecutive individuals who got admitted in a geriatric care facility in France and Switzerland, it's a collaborative study. Out of these 70, when they did a polysomnogram and took their sleep questionnaire, 46 of them had severe sleep apnea and 21 of them had moderate sleep apnea. That's a huge, huge figure. So this is an eye-opener. It is, this figure in the geriatric population is far larger than the figure you will find in the community. Of course, there is a bias to this assessment because they've gone into a community care facility. This is not a population-based study. But if one did a population-based study in geriatrics, one would find that it's much higher than in younger people. So I think that's going to open a new vista. So geriatric medicine people will also have to learn about sleep physiology.
Thank you, sir. My next question is, what can a sleep specialist further specialize in?
Basically, I feel sleep medicine is a subspecialization. Okay. And people pick up sleep medicine out of interest, or they, after their specialization or super specialization, they go into it like for 1 year training. But just to elaborate on it, sleep medicine have got more than 100 type of sleep disorders. There are 6 categories of sleep disorders that have been listed. That is insomnia, sleep disorder, breathing, hypersomnia of central origin, movement disorders, circadian rhythm disorders, and parasomnias. So if usually you will be handling all type of patients, but I have seen couple of people who narrow down their interests after getting trained in all these fields. Some people just focus on movement disorders like restless leg syndrome patients and parasomnias. They focus mainly on that category. There are some people who have 100% focus on circadian rhythm disorders and the circadian physiology. There are some people who will go into the research aspects of these disorders. And some people, majority of them, they will be practicing for looking after sleep disorder breathing patients or insomnia patients. So people do go and focus on these subtopics in sleep medicine, but majority of them will practice it as a specialty covering all types of patients coming into the clinic.
Yeah, I think as time goes by, maybe I foresee a future where, and we clearly are going to live longer. We are already living longer in many parts of the world. I foresee that somewhere there will be a subsection of geriatric sleep medicine too. And I think there is a big need for it. We need to understand all our physiologies. And there is so much that we don't know, because remember, the patient doesn't read a textbook when he goes to a doctor, right? So what is a textbook? Is the assimilated, distilled synopsis of our past experiences in medicine. And every time we see something new, it gets written as a case report. So in the next or the one after the next edition of the textbook, those case reports, if there are at least 10 of them, will find their way into a designated entity. So our experiences will change with our observations as more and more people see patients. And the more we dwell into it, we'll find new things. We found lymphatics by accident. Who knows what we'll find 5 years from now? 10 years ago, or maybe about 15 years ago, we had a lot of data coming in from sleep research that demonstrated that one of the key functions of REM sleep, the rapid eye movement sleep described by Kleitman, is not just that we dream randomly in our sleep, but if you see the function of REM sleep, it is emotional salience. That means if we have good REM sleep in our 8 hours of sleep, it makes us emotionally stronger. I can exemplify that suppose you went to the office and your boss had a bad day at home, and you did something which was a minor misdemeanor, and the boss really took it out on you and slammed you in front of all the other colleagues at work, and you found it emotionally traumatizing. Now, if you do not sleep at night and if you don't have good REM sleep, that emotional trauma will be replayed by the brain again when you see the boss. So it's not just the memory of the thing, it is the emotional trauma. So what REM sleep is doing is that it is gradually, every night of good REM sleep, it is taking away and eroding away the emotional trauma of a traumatizing experience. So it is therefore not difficult to understand that people with soldiers who have a post-traumatic stress disorder, actually one of the basis for that is poor REM sleep in their experiential times after the trauma. And many of the medications and strategies are being explored. So how to optimize this REM sleep? So we are still at a very nascent stage in understanding this. So psychiatry, a lot of things developed in psychiatry by observational analyses of patients' narratives, and we classified them: bipolar disorder, cyclothymic disorder, schizophrenia, depression. But these feelings of the brain often have a basis in disordered sleep physiology, and psychiatrists have woken up to that. So many psychiatrists take that history and try and optimize sleep hygiene for their patients. So I think somewhere with research in time, I think I also see other subspecialties coming in. So psychiatrists, cardiologists, I mean, there are kinds and kinds of cardiologists. So a cardiologist will be called in to, say, look at a patient who has sick sinus syndrome, which is a rhythm disorder. And that patient, middle life, also has a little bit of congestive failure, but didn't have standard risk factors. The coronary angio is normal. Now, the smart cardiologist should get a sleep study done, because if that person has sleep apnea and vulnerable genes, you have severe sleep apnea can predispose to congestive failure and cardiac rhythm disorders, amongst other things. So integration, because sleep has so many physiological ameliorative benefits, almost every specialty will need to know about sleep, and sleep will have to have inputs into it from every specialty. That's the way I see it, I think.
No, I agree with you, Dr. Desai. The most recent field of medicine, which is now feeling the importance of sleep, is obstetrics, where they are showing that sleep apnea during pregnancy can have detrimental effects on mother's health as well as on the fetal health. And this field is now coming up in a big way, obstetrics and sleep. So I think you very rightly said, every specialty have to learn about sleep, and this specialty of sleep medicine cuts across all the specialties.
Thank you, sir. This brings me to the next question. What types of procedures do sleep specialists perform, and what are these types of patients that a sleep specialist would encounter the most?
So I think the patients will be the same patients walking into your clinic. You have to identify them. They will come with their complaints. So they will not, usually people do not come into the clinic and say, oh, I have a sleep problem, or unless they are suffering from insomnia, then they do come and tell. Otherwise, they come with all funny complaints. Like I've seen patients coming with chronic cough, which is not being taken, nothing is working on that cough. And once we saw that, took the sleep history, it was obstructive sleep apnea leading to GERD and leading to cough. Treated obstructive sleep apnea, cough disappeared. They may come to the clinic because of impotence problems, especially males. Absolutely. And nobody is even bothered to take the history of whether they are suffering from sleep apnea. Like my journey into sleep apnea started with a patient who suffered from impotence, and I picked up that this guy had severe obstructive sleep apnea, and the guy was a poor guy, couldn't buy CPAP, and only question he asked was, is there anything else that can be done for his sleep apnea? And I told him lose weight. He was 120 kgs. And he said, how much? I was in my training days and textbook said 10% of your body weight. And I told him, lose at least 30% of your body weight. 120 kg means 30%, 40 kg you have to lose. I myself didn't have faith in that. But that guy, because it was the life now, the life is going to be devastated with that issue. Marriage was on divorce. And he has lost his job because of sleepiness, met with an accident, cannot drive. And economic, social, personal pillars all gone. That guy, in 6 months' time, lost 40 kgs. 6 months later, he came to the clinic at 80 kgs. Sleep apnea disappeared. Impotence gone. Got the job back. 6 months later, he became a father. And the wife was pregnant. That was an eye opener for me. That oh my God, people are not going to come to your clinic and tell you that they have this particular problem. They'll come with all sorts of problems. It's you who have to identify what's the underlying cause. Yeah. So basically, but if you want a textbook picture, we'll get insomnia patients, we'll get sleep apnea patients, we'll get movement disorders, we'll get circadian rhythm disorder patients. But they do not come with these complaints. They come with very funny complaints. Parents bring their children, oh, he don't go to bed early, and it's very difficult for them to wake up for school. And because of that, academic performance is suffering. It's us who have to understand what's happening with these kids. So that is on the part of the patient's part. Dr. Desai, you can add on it before we start the procedure.
I'll share one more anecdote like the one you have. This is my something that changed my perspective of medicine. So in 2014, I saw a patient who was a very eminent chartered accountant, aged 52 at that time, in one of the central Indian cities. And he was referred to me by the CEO of the hospital there, saying that nobody has been able to understand what's wrong with him. Doc, please have a look. So this guy is a chartered accountant, mesomorphic habitus, hypertensive, not diabetic, does not smoke, does not drink. Very busy, because at that time in 14, I think he was working with one of the PSU banks, and they were very busy with non-performing assets for the government. His problem was that he used to faint 7 to 9 times in a day. So he would just pass out and drop like a log. If you ask his wife, what do you see? He sweats a little bit, she passes out. Sometimes he vomits after the episode. Sometimes he gets a feel that he has the urge to defecate. Very, very typical symptoms of syncope. And on some episodes, he has a little tightening of his teeth and his body becomes stiff for a few seconds. Now, so it's not difficult to understand that this is a syncope, but the oddity was that this would happen 7, 8, 9 times in a day. And so he saw lots of doctors in his city. Video EEGs were done, 3 of them. MRIs were done, 3 Tesla MRI. all normal. Carotid angiogram, cardiac evaluation. Came to Bombay, went to Bombay Hospital, saw one very eminent cardiologist. So coronary angiogram was done, stress test was done, tilt table was done, and even the tilt table was okay. It was done in the hospital. And while the tests were being done, he would get these episodes. So much so that on one of the flights, he passed out at Bombay airport, and the Jet Airways was working at the time. Jet Airways didn't allow him to board the flight because they said, go to your doctor, get it sorted. When we have a certificate, then we'll allow you to fly. And with all this, the cardiologist told him that go and see a neurologist. I don't know what's wrong with you, but your heart is like a 40-year-old. You're not 52-year-old. So ask your neurologist to sort it out. And that's how he came to my chamber. And when I heard of this whole story, I was wondering, what am I going to do here? The only difference was that when I took the entire story and the rest of it, perhaps I was the first person to take also a sleep history. And his sleep history was resoundingly obstructive sleep apnea. When I asked his wife, she said, हाँ डॉक्टर साहब एक खराटे तो ट्रक चलाते हैं 5th गियर में, और जब से शादी हुई थी तब से चलाते हैं, अब तो लेकिन 4th 5वीं गियर में बहुत जोरों से चलाते हैं, मैं तो दूसरे कमरे में जाके सोती हूँ. And yes, he then admitted that there was daytime drowsiness, he would go to sleep, and long and short was that his apnea-hypopnea index turned out to be 47, and we put him on CPAP, and we had numerous counseling sessions. He started exercising. He lost some weight, though he wasn't really overweight, but he did lose some weight. He started exercising. I urged him to do resistance training, my favorite subject, put him on CPAP, and everything stopped. So when I shared this case even on the National Forum in Delhi, in one of our meetings, many people said, syncope due to OSA? And the fact is that it's published. It is very much there. There is a small little letter to the editor in the Journal of Interventional Cardiology from Grenoble in France, where they have got 11 cases of unexplained syncope. All of them had sleep apnea. So you can imagine that what doctor said, that patient doesn't read the textbook. He comes with a problem. It is your responsibility in your entire evaluation, not only just to look at his daytime physiology, but to also look at his sleep health. And every once in a while, you will find a funny clinical presentation. One of the things people don't realize is that many patients with chronic unremitting pain syndromes have a comorbid sleep disorder. So there's a wonderful paper written by Bryce Mander and Adam Krause from Helen Willis Institute of Sleep Medicine in Berkeley. It's called, very provocatively, it is called The Pain of Sleep Loss. So what they did in that experiment was that they just took pain threshold studies and they looked at sleep deprivation and sleep replenishment. And when you are sleep deprived, your pain threshold drops in that experiment. So clearly, our pain processing physiologies in the brain, say someone who has migraine, also need optimum sleep. So if one has a sleep disorder, you will have some chronic pain condition which is unremitting. You've got to optimize their sleep besides giving them medications for neuropathic pain. So I think the scope for sleep medicine is huge. It's just huge.
Thank you. My next question is, what factors should one consider when choosing sleep medicine course as a career? And what are the economic realities of medical education and career in sleep medicine?
The economic realities of medical education and a career in sleep medicine. Now, the economic realities, I will say it's a very subjective matter. What one aspires, that can vary from person to person. But all I can say is, you will have a decent life. And you will have a very fulfilling career. I will say that.
I tell all my students, no doctor stars. First thing you need to understand.
Yes.
And a good doctor will always be well-to-do. Because patients go to the doctor whose patients come back and say, first theek ho gaya. If you're doing a good job, there's no way that you're not going to do well. And there are too many people in India.
True. And to like Dr. Desai said, Food, shelter, clothing, those basic necessities, and on top of it, certain amount of luxury. That is how I put it. But again, this is a very relative matter. Somebody may want to buy a Mercedes, whereas another person may be happy on a bicycle. Both will have a good life, but it's the satisfaction level which can vary. But like I'll just say, if you go into it with passion and with the idea of making a difference to patients' lives, I think you will end up with a fulfilling life.
Absolutely. Absolutely. I don't think we should measure anything in economic terms.
No.
Medicine is a fulfilling occupation. It is a profession that is so rewarding because there is somebody, not just the patient, but their family saying that, "Arey, Doctor Sahab, theek ho gaya bilkul." That itself is a reward in itself. On top of that, they are paying us. So that's additional.
Thank you, sir. My final question is, why is the future of sleep medicine so bright?
Because everyone needs to sleep. And everybody is sacrificing their sleep. That is why the future is bright for sleep medicine.
Yeah, absolutely. I think the future is bright because one thing is that civilization and technical advances are somewhere losing the adage that early to bed and early to rise makes Jack very wise. So we what we learned as say an aphorism in childhood has gone forgotten because we think the technical advance gives us more hours of the day. Technical advance is not to give us more hours of the day. Technical advance is only to make the time spent and the effort involved in doing a job be needed less. That's technical advance. But it cannot be at the expense of our sleep. But unfortunately, it's happening. And because of this, we are in a pandemic of sleep-related disorders where despite technical advances, we are not healthier. We need to see medical professionals because of all these factors. So I think there is no question that the future is bright for anyone who wants to do sleep medicine.
Thank you so much, doctors. This brings me to the end of the discussion. I would like to thank our eminent speakers for participating in our 8-year celebration program and addressing some important questions about sleep medicine.
I think it was a very wise thing to do. And I'm glad that you did it because it's going to be very fruitful for everyone, not just from a career perspective, but it's our responsibility to understand our health. And if we are healthy, we are going to walk our talk. Only then we can tell our patients what they need.
A very good initiative. And if audience can remember one message, that tell your patients, tell the community, sleep well, sleep on time. They should tell it to everyone they see in their clinics or whenever they get to address a gathering, they should bring it to the attention of the public. So if they can do that, I think this initiative will do a lot of people a lot of good.
Thank you, doctors, for such a riveting and insightful discussion. I am sure it will help our doctors explore different avenues in the ever-changing field of medicine. Thank you to our dear viewers and stay tuned to the ACE 8YC exclusives on dealing with difficult patients, the medical legal aspect. Tomorrow, 6 p.m. I will see you all again. Until then, stay safe and happy dog flexing.